Good evening, Gary Harris, Charles Sturt University student in the Master's degree in Critical Care Paramedicine. This evening we're talking about seizures. We'll discuss seizures by addressing pathophysiology, clinical features, physical examination, paramedic care and pharmacology, relevant investigation, transport decision-making, and the leadership role a senior paramedic undertakes. Let's define seizures. This is when an uncontrolled, abnormal discharge of cortical neuron activity in the brain that all occur at the same time. The level of these abnormal discharges will determine the level of convulsive activity. The increase in neurotransmitter activity is due to the increased activity of the glutamatergic system and decreased inhibition by the gamma aminobutyric acid, shortened as GABA. The possible changes in the membrane potential of a group of neurons act as a focus for seizure activity and may be stimulated by conditions such as hypoxia, hypothermia, hypoglycemia, hyponatremia, brain injury or trauma, and drugs or illicit drugs. The primary cause may be a defect in the GABA inhibitory system or abnormality in the excitatory transmission. A very simple mnemonic AEIOU tips, but they help us quickly have a look at the types of things that could be of relevance in the cause of a seizure. Anoxia, alcoholism, clearly epilepsy, but we will discuss later how a seizure and epilepsy are distinctly different. Electrolyte imbalance, insulin, blood sugar levels up or down, an overdose or an opiate withdrawal, renal failure, trauma, cancerous tumours, infections, illnesses, pregnancy and preeclampsia or eclampsia, and of course a transient ischemic attack or a cerebral vascular accident. Other causes of seizures, very clear to note that age is specific to the types of etiologies you can anticipate. Perinatal hypoxia and ischemia in the neonates to 1 month, intracranial hemorrhage and trauma, acute central nervous system infection, metabolic disturbances, again, a blood sugar, or electrolyte imbalance and hypomagnesia, or peroxidine deficiency, drug withdrawals, developmental disorders, and genetic disorders. Now, from 1 month to 12 years, we might experience that common febrile seizure, or genetic disorders, the result of a metabolic or degenerative or a primary epilepsy syndrome. Central nervous system infection, development disorders, and idiopathic causes, but also, of course, trauma. In our adolescent years, from 12 to 18, trauma is a big causation of isolated seizures, and also genetic disorders, infection, brain tumor, illicit drugs, or idiopathic cause, just unknown. In young adults, again, trauma is a major causation of a seizure, alcohol withdrawal, illicit drug use, brain tumor, and unknown causes. In the older adult, 35 and above, cerebral vascular diseases are an issue, as can be a brain tumor, alcohol withdrawal in alcoholics, metabolic disorders, uremia or hepatic failure, electrolyte abnormalities, hypoglycemia, early onset of Alzheimer's disease and other degenerative central nervous system diseases. And there may just be an unknown cause. The literature reflects that there's still a lot of study to be done to ascertain a clearer understanding about the phenomena. So, pathophysiology of a seizure. A seizure can be a single event with a number of causes, as we've highlighted in earlier slides. Outside causes beyond the central nervous system affecting it, the insult of trauma, the insult of drugs, alcohol, fever, electrolyte imbalance, and, interestingly, sleep deprivation. Students can relate to that. And several diseases. 10% of Australians will suffer a seizure, generally a one-off, and only 3 to 3.5% develop epilepsy. It's important to note that there is a difference between seizures and epilepsy. Epilepsy is repetitive and will more likely have an identifiable etiology. So the pathophysiology. Gamma-aminobutyric acid, shortened as GABA, has a primary function as an inhibitory neurotransmitter maintaining motor control. And the activation of these receptors see an influx of chloride and a hyperpolarization of the neuron and inhibits action potential. Now this diagram really reflects it so well. We can see the neural firing during seizures. Neural firing is triggered by altered signal propagation. And this may result of abnormalities in the neural membrane stability or if the connections among the neurons have a fault. Bursts consist of sodium-dependent action potentials and calcium-dependent depolarizing potentials. The open voltage gated calcium channels result in a flood of neurotransmitters of glutamate into the synaptic cleft and increase the accumulation of glutamate and menthol deaspirate. And many other chemicals will influx such as sodium and calcium ions through the channel gated by these receptors, and this leads to neural hyperexcitability. Now, the uncontrolled increase in disinhibition is also one of the key events in generating seizures, such as a reduction in the GABA inhibition, which is necessary to produce the synchronous burst discharges in the group of these cells. So the clinical features. What do these seizures look like and what aspects do they present? Well, there can be a clear absence, a sudden lapse in awareness and responsiveness. It looks like somebody's just staring or daydreaming, or tonic-clonic. The body stiffens, the tonic phase, and then the limbs begin to jerk rhythmically, and that's the clonic phase, generally what we can consider a full seizure. And then the myoclonic, sudden single jerks of a muscle or a group of muscles that may last no more than a second or two. And the tonic, this can occur when a person is asleep or awake and involves a brief stiffening of the body, arms and legs. Or legs. The person will suddenly fall if standing or sitting. And atonic, brief seizures that cause a sudden loss of muscle tone. And the person often falls to the ground or will have a sudden head nod if sitting. Clonic, although uncommon, they cause jerking in various parts of the body. So, as a result of a seizure, we can end up with clinical features of an altered level of consciousness. We're posectal, confused, very lethargic. Potentially, the patient presents with incomprehensible speech. They're inattentive to your questioning and demonstrate considerable fatigue. I have been to situations where they are aggressive, but it's automatism, and they don't actually know they're doing it, and it's not personal, and it's not an attack on you as such, but you must very much be aware of your personal safety and the danger to you and others and themselves. They may complain of a headache or tinnitus. They may have nystagmus, eye rolling and roving eye, or tonic and clonic posturing. They may have been incontinent and have an increase or loss of tone, and they may have a repetitive action. Also, they could have oral trauma, bleeding mouth, cut tongue, lips. Prolonged seizures result in hypoxia and hypercarbia and progressive lactate and respiratory acidosis, increased temperature, increased blood pressure and heart rate, and of course, we must watch the blood sugars because often that can be a trigger to having a seizure. And also hyperkalemia, dysrhythmias, cardiac dysrhythmias, electrolyte imbalances. Consider also in your pregnant patients eclampsia or preeclampsia, although this is considered very rare. But you must be aware of the potential for seizures or actual seizures, which are very significant events in the pregnant person. Don't overlook that a seizure could be secondary to a transient ischemic attack. And sadly, not as prevalent as it was in the 80s, but HIV still, seizures are very common in this disease. Now, in our physical examination, clearly we, as in all paramedic response, maintain our personal safety and the safety of others. And for our patient, we do all we can to prevent further injury. It's important for us to record the time and establish the duration of the seizure if it's occurring while we're present. And the priority, of course, is airway protection, maintenance, and oxygenating this patient. We engage in pharmacology that participates in the cessation of this ongoing seizure activity. We identify and treat the precipitating factors, and we identify and treat any complications we've also found in our differentials. But be very much aware that when you're administering pharmacology, you must be prepared to ventilate this patient and have all your equipment ready for rapid care of respiratory care of your patient. Now, ongoing intervention continues. I've addressed paramedic safety. Clearly, standard cares at our senior paramedic level go without saying. Our vital signs survey, peripheral perfusion status assessment, respiratory status assessment, and Glasgow coma score assessment, and engaging our crew to assist us in getting our patient assessment conducted in a timely manner. So ensure that clearly that this patient is protected from any further seizure activity, and we're going to do that by getting IM pharmacology on board as soon as we can. The aim of this assessment is also to identify any life threats and treat them immediately. For example, early BGL or any other recognisable causes. While conducting your physical exam or having a colleague engaged in doing so, ascertain from bystanders or family, what's the history of the presenting problem? Does this person have a Medi-Alert bracelet on? Do they have paraphernalia with them that suggests that they may be an epileptic or have a cause for seizures? But also find out what the level activity was in the body movements and twitching and head turning and motor activity, so that you can ascertain what type of seizure that they've had and report the same to you in your medical handover. Ascertain the relevant medical history. Have they suffered any recent head trauma, or exhibited any unusual behaviour. What's their medication? Are they on like Dactyl or Epilim or anything else that could be indicative that they may already be suffering a form of epileptic seizures? Or are they allergic to something and they've had an antigen cause a seizure? And review all their systems so that we are completely across any other etiologies that could be causing this person to have suffered a seizure. Ongoing intervention, clearly ascertaining important family history. Consider the environmental setting that this person's in. Are they potentially exhibiting dysfunction in terms of their drug use or alcoholism? Excuse me. And also your partners can do environmental surveys. Is there appropriate food and hydration occurring here, that the patient's not dehydrated? And secondary survey noting any signs of head trauma or injury to the tongue post-ectal. And clearly we need a 12-lead ECG to ascertain if any dysrhythmias, identifying hyperkalemia or any other electrolyte imbalances. And also be aware that there are people who have pseudo-seizures. We call those psychogenic non-epileptic seizures. And consider all the differentials that you may or may not have considered. So clearly treatment is your personal safety, danger, patient's safety, those around you, their safety, and we proceed with our airway care, identifying that our airway is patent. And if the patient is seizing, we certainly don't force anything into the person's mouth while they're seizing. Breathing, we're going to administer oxygen and, if necessary, assist with IPPV. Confirm that they're not hypo or hyperglycemic, ascertaining their BGL is within normal limits. Administer a DASLAM IM initially. Always refer to your field reference guide and double check your drug dose and complete the minimum of the 5 rights of drug administration. Absolute minimum. There's up to 8. The list is, you can add to it all the time. Be aware as a registered professional, you have significant responsibilities to ensure an accurate and timely administration of pharmacology. When time allows, establish large bore IV access. Now be prepared to have to intratracheal intubate this patient if they're unconscious and it's indicated. Now, if there is significant issues involved with this patient and RSI is indicated, in the state of Queensland, you will have to activate the HARU as they need to lead that initiative. Anticonvulsants are clearly drugs that suppress the excitability of the cortical neurons by stabilizing the nerve cell membranes, affecting the movement of the sodium and calcium channels, and increasing the activity of the transmitters such as GABA to bring back some homeostasis by decreasing the glutamate activity, and a combination of all the above. Our effort is to restore homeostasis in the central nervous neurons. The first drug of choice is benzodiazepam, acting on the inhibiting the neurotransmitter GABA, and it's clearly indicated for a seizure. Its presentations in a 5 milligram and 1 ml ampule, and its onset is 5 to 15 minutes IM or 1 to 3 IV. Now, clearly, just let me reiterate, QA's protocol requires the first dose of midazolam must be administered via nasally or IM until an IV is established. So it must be in a timely manner. Clearly, ensuring that your dose is age specific and that you've checked with your colleagues to ensure that the dose is the correct dose, the right route, right person, right documentation, right time, etc. And it goes on. And the right to refuse. However, if they're seizing, they're not going to be refusing, clearly. The child doses are there. Again, always double checking and ensuring that you're compliant with drug administration protocols. Now, another drug, if we have prolonged fitting of more than 20 minutes and we have a situation of 2 or more seizures occurring, we have convulsive status epilepticus. Now, the drug levotiroxine is another S4 drug, and it's a second-generation anticonvulsant. It's non-sedating anticonvulsant, and it is given at 30 milligrams per kilo, single dose only. Now, it comes in a 500 milligram vial, and for your pediatric, clearly over 3 years, 30 milligrams per kilo single dose to a total of 2 grams. And if they're under 3, the maximum dose is 450 micrograms. Now, it's contraindicated for less than 1 year. And if the seizure is a result of toxicology, you must call a QAS consult line, take up with the High Acuity Response Unit coordinator or the medical officer. Always be aware of the reversible causes. If you've got a prolonged seizure, they're going to be suffering hypoxia and hypercarbia. They're going to have progressive lactic and respiratory acidosis. So fluid may also be indicated. And hypothermia, hypertension, tachycardia all result of this extra motor activity that's occurring in the central nervous system. And they'll be burning up sugar. So be aware of that. And dysrhythmias with peak T waves, of course, indicated hyperkalemia. Now, in terms of our transport decision-making, you have to conduct a dynamic risk assessment at all times in every paramedic case. And as the lead, you have the overall responsibility to coordinate and ensure that if this patient has been deemed time critical, that you've recognised this patient's condition and the likelihood of potential further deterioration. You've identified and established the appropriate clinical management, and you're ensuring that it's all agreed that the correct destination for this patient has been decided and that it meets appropriate criteria for the hospital that you're going to be attending. Now, early notification is entirely appropriate to the receiving facility to ensure that they are prepared and that they've activated appropriate personnel to provide the adequate patient care pathways to enhance this patient's ongoing outcome. In this decision making, clearly, as a lead paramedic, it's your overall responsibility to ensure that this is coordinated seamlessly and that you engage with your team in a respectful manner that empowers and engages and allows a team review to occur to make sure that the progress so far is agreed upon with everybody and that they identify that nothing has been overlooked. Now extricate this patient to the ambulance and make your way to the emergency department. Again, a good idea with a patient who's just had an episode of a seizure. Bring the stretcher as close as possible. Use a combi carrier or device to extricate to the stretcher if required. And make sure you've clearly sit-repped the situation and advise your current treatment and your expected time of arrival at the emergency department. Constant reassessment of the patient and modifying any treatment as required. Now, as a senior paramedic, you have a clear leadership role. Your leadership role has many responsibilities. As a registered professional, working with other registered professionals, you clearly have to afford them unremitted positive regard, demonstrate respect for them, respect for the patient, You have to be culturally engaged as well, respectful of the cultural boundaries that your client may have due to their own identification. And also, you have to engage in such a way that is going to enhance the patient outcome. You need to quickly identify the life threats and engage with your staff in a way that ensure that the patient care is addressed proactively and appropriately in a timely manner that's going to enhance the patient outcome. Oxygenation and administration of the anticonvulsant in a timely manner is also required, ensuring that people are engaging either intranasally or IM so that they're compliant with protocols. Otherwise, you can be held accountable and reported to the Q Health Ombudsman or referred to APRA for non-compliance as a registered professional to demonstrate competency. So ensure that if there's things that aren't happening, initiate corrective action yourself if necessary, but encourage others to engage and be proactive participants. Manage the comorbidities that may be presented in this patient that may have been the triggers for this seizure, and ensure that the team have all the diagnostic tools applied. Ensure secondary therapies are initiated, as indicated, that large bore cannula has been inserted, fluids hung, and ensure that all pertinent history from the family and bystanders has been obtained and hasn't slowed your egress from this situation. Ensure that you have also delegated somebody for a final recon of the scene. Ensure that we've not left any consumables at the scene and that everybody has ensured that the family have been informed and assuming the patient is again conscious, that they're informed and aware of what's occurring and that all consent and the criterion to ensure that everyone's needs are met have been completed. Follows as the references, and that concludes our slideshow on seizures. I hope it's been informative and helpful to your practice.